Chalo bachcho, welcome. Today, we are going to tackle a very, very important topic, not just for your exams, but for your entire clinical life, and that's the kidney. More specifically, we're diving deep into glomerular diseases. We're going to understand what happens when the body's most sophisticated, high-tech filter starts to fail. So let's get started.
First things first, just look at this number on the screen, 1,700 liters. Can you believe it? That's the absolutely staggering amount of blood our two small kidneys filter every single day. Just imagine the workload on these organs, nah? It's a true marvel of biological engineering. Bilkul.
So what is the kidney's main job, fundamentally? Well, think of it just like this. It takes a massive river of blood, all 1,700 liters of it, and with just incredible efficiency, it turns it into about 1 or 1.5 liters of urine. And the star of this whole show, the hero of the process, is a tiny little structure we call the glomerulus. Now, to understand what goes wrong in any disease, we first have to understand the normal design, right? So let's go inside this super filter. For the rest of our discussion today, I want you to imagine the glomerulus as a kind of high-security fort, a chela. It's perfectly designed to keep all the precious things in the blood while very intelligently throwing out all the waste products. So what you're seeing here, this isn't a drawing. This is an actual image from an electron microscope. This is the fortress itself, the glomerulus. And at its heart, it's really just a specialized little ball of tiny blood vessels, capillaries. You can clearly see the channels where the blood flows, the cells lining these channels, and these very special cells wrapped around the outside. But the real strength of this fortress, its biggest secret, well, it lies in its walls. So let's zoom right in. The entire effectiveness of this filtration system, it all comes down to the 3 highly specialized layers that make up the wall of these tiny capillaries. It's a 3-layer security system, so pay close attention now. First, you have the endothelium, which has tiny windows, or fenestrae, that let fluid pass but block big things like our red blood cells. Second, you have the glomerular basement membrane, the GBM. Now, this is the main structural wall, the most important barrier that stops large proteins like albumin from getting out. And finally, the third line of defense, the podocytes. Think of them as the final guards at the gate, with their interlocking little feet. All together, they create this incredibly beautiful and selective filter. Okay, so that's the ideal situation. But what happens when this perfectly designed fortress gets damaged? When things start to go wrong, the glomerulus shows signs of injury. So let's now look at the pathology, the signs that this fortress is beginning to crumble. When there's an injury, the glomerulus basically reacts in 4 main ways. Think of these as the smoke and cracks appearing on the walls of our fortress. You can see hypercellularity, which just means too many cells are crowding the place. The basement membrane can get thick. Then there's hyalinosis, which is when leaked proteins just deposit and clog everything up. And finally, sclerosis, which is just a fancy word for scarring. Simple as that. So this is the crucial question. Who is attacking this fortress? Who is causing all this damage? Well, in most cases of primary glomerular disease, the main attacker, the shocking villain of our story, is our own body. The enemy is literally coming from within. The primary mechanism here is called antibody-mediated injury. You see, our own immune system, which is supposed to protect us, it gets confused. It starts creating antibodies that, instead of fighting viruses or bacteria, they start attacking the structures of our very own glomerulus. This friendly fire is the root cause of most of these primary glomerular diseases. And this slide illustrates the 2 main strategies of this immune attack brilliantly. Just look at your screen. These are immunofluorescence images. On the left side, you see this lumpy, bumpy, granular pattern. And on the right, it's a smooth, clean, linear pattern. These are 2 completely different pictures, and they tell 2 totally different stories of how this attack is happening. So that lumpy, granular pattern, that comes from what we call in situ formation. Basically, immune complexes, that's the antibody and antigen stuck together, they're forming right there on the spot inside the glomerulus, creating these clumps. But that smooth, linear pattern, that happens when antibodies launch a full frontal assault, attacking the entire basement membrane along its whole length. That's what creates that clean, continuous line. All right, so we have seen the battle at the microscopic level. Now, let's step back and look at the clinical picture. In your clinics, what is the patient actually going to present with? This microscopic damage, it translates into 2 major clinical syndromes that every single one of you must know. First up is nephritic syndrome. Now listen, the I in nephritic is for inflammation. The fortress is inflamed, it's under attack. And this leads to the classic signs: blood in the urine or hematuria, high blood pressure, some swelling, and of course, a drop in kidney function.
And the second major syndrome is nephrotic syndrome. For this one, you can think of the O as a big O-shaped hole in the filter. Here, the main problem isn't so much inflammation, but a severely damaged, leaky filter. This leads to a massive, heavy loss of protein in the urine. We're talking more than 3.5 grams per day. And that is what causes the severe swelling or edema and all the other metabolic problems. Now, this table is absolutely crucial for your exams, so please pay close attention. It clearly summarizes the differences. Nephritic syndrome, it's all about inflammation, leading to hematuria and hypertension. Nephrotic syndrome, it's all about that leaky filter, causing massive proteinuria and severe edema. You must master this table. It's very high yield.
So, we end with this thought. We've seen the fortress, we understand how it's built, and we've seen how it gets attacked from within. We now know that the enemy is our own immune system. So the big question for all of you future doctors is this: how do we stop this civil war inside the kidney before this fortress is completely and permanently destroyed? Think about it.
Welcome, students. Today, we're going to explore something absolutely critical. You know, our kidneys have millions of these tiny, amazing filters that are constantly cleaning our blood. But what happens when this magnificent filtration system, the glomerulus, goes wrong?
So just imagine the glomerulus is like a high-tech chai ki channi, a tea strainer for your blood. It's supposed to keep all the good stuff in, like proteins and cells, and let all the waste out. So what happens if this super advanced channi gets damaged?
Well, essentially, there are two main ways this filter can fail. In what we call nephritic syndrome, it gets all inflamed, angry, and starts bleeding. But in nephrotic syndrome, it develops these big holes, gets super leaky, and starts losing tons and tons of protein. Two very different problems, two very different stories. Chato, here's our plan for today. We'll look at the angry, inflamed kidney, then the leaky one. After that, we'll become detectives and look for clues under the microscope. And finally, we'll understand the kidney's dangerous, vicious cycle. Let's get started.
Right, so first up is nephritic syndrome. The problem here? The main issue is inflammation. Just think of the kidney as getting really, really angry and swollen. And when the glomeruli are inflamed like this, you see these classic signs. The funda is simple. The filter is damaged, so blood leaks into the urine, that's hematuria. The kidney isn't filtering well, so waste builds up in the blood, that's azotemia. And the body holds on to salt and water, which, you guessed it, leads to high blood pressure. It's a very clear picture of an unhappy, dysfunctional kidney.
A very common cause for this, especially in children, is something called post-streptococcal glomerulonephritis. It's actually a fascinating story. A bacha gets a simple sore throat, gets better, and then, weeks later, boom, the kidney gets inflamed. Why? Well, the body made these things called immune complexes to fight the infection, and now those complexes have gotten stuck in the kidney's filter, causing all this trouble. Now, what's really interesting is when you look under the microscope. Look here. On the left, that's a normal, healthy filter, nice and open. But look at the one on the right. See how crowded and jam-packed it is? That's what we call hypercellularity. It's just full of inflammatory cells that have rushed in, completely clogging up the filter. And here is the proof. Using a special stain, we can actually see the troublemakers. All these little glowing green dots, those are the immune complexes that got stuck. They are like the fingerprints left at the crime scene, proving this is an immune attack on the kidney. And if we zoom in even further with an electron microscope, we see these big, dark lumps on the outside of the capillary wall. We call them subepithelial humps, and they are the classic textbook finding. This is the hard evidence, the actual piles of immune complexes causing all the damage.
Okay, so that was the angry kidney. Let's move on to the second big problem, the nephrotic syndrome. This one is all about a leaky kidney, a filter that's losing massive, and I mean massive, amounts of protein. So what's happening here? The filter's pores get way too big. Huge amounts of protein, especially albumin, just pour out into the urine. Now, when you lose that much protein from your blood, you can't hold on to water properly. So fluid leaks out into your tissues, causing swelling all over the body. That's the edema. And the liver, trying to help, starts pumping out more fats, leading to high cholesterol. It's a complete domino effect, all starting from that one leaky filter.
Now, see, Bacha, this is a very important point for diagnosis. The most common cause is totally different depending on the patient's age. In children, it's almost always something called minimal change disease. But in adults, we're thinking more about conditions like membranous nephropathy or FSGS. This is absolutely crucial to remember.
Now have a look at this. This is a glomerulus from a child with minimal change disease. Under a regular microscope, it looks perfectly normal, doesn't it? That's why it has the name minimal change. It's very, very deceptive.
So here's the crucial point. The real damage is invisible with a standard microscope. You need the powerful electron microscope to see what's really going on. The tiny, delicate foot processes of the podocytes, which are supposed to wrap around the capillaries, they're completely flattened out. We call this effacement, and that is what's destroying the filter and causing the massive protein leak.
Okay, now let's talk about the adults. A very common cause of nephrotic syndrome in adults is membranous nephropathy. And here, with this silver stain, you can see it very clearly. The filter walls, the capillary walls, they've become really thick and stiff all over. It's this thickening of the membrane that's causing the problem. You see, each of these diseases leaves behind a unique pattern of destruction. It's like a footprint at a crime scene. So now, let's put on our detective hats and look at some more of this microscopic evidence. Right. When you see this, it is a very, very bad sign. This is called a crescent. It happens when there's a really severe injury and cells just start multiplying like crazy in the space around the glomerulus, forming this crescent shape that literally crushes the filter. This is the sign of a kidney that is failing very, very rapidly. And this is beautiful. This picture perfectly explains that wall thickening we saw earlier in membranous nephropathy. See all those fine granular green dots? Those are immune complexes again. But here, they're scattered all along the capillary loops, causing that thick, stiff wall that leaks protein. And finally, we have FSGS, another major problem in adults. The name actually tells you the whole story. The scarring, or sclerosis, is focal, meaning it affects only some of the glomeruli. And it's segmental, meaning it affects only parts of those glomeruli. But don't let that fool you. This leads to permanent scarring that destroys the filter bit by bit. So what happens in the long run? Unfortunately, any kind of initial damage, doesn't matter what it is, can kick off a very dangerous downward spiral.
This diagram here shows the vicious cycle perfectly. You lose some filters, right? So the remaining ones have to work harder to pick up the slack. But that extra strain, that overwork, actually damages them. So you lose more filters and the cycle just keeps going, getting worse and worse.
And this is a critical idea to understand. This progression from injury to scarring, this is the final common pathway. It doesn't matter what started the problem, an infection, an autoimmune disease, anything. They can all lead down the same path to scarring, which eventually leads to end-stage kidney failure. This is how so many patients end up needing dialysis.
And that, my dear students, that is the million-dollar question. It's the challenge that drives all of our research and our treatment strategies today. How do we stop that initial injury? And just as important, how do we break this vicious cycle once it starts? Thank you.
Namaste, students. Welcome. Today, we're going to tackle some of the most challenging, but also the most fascinating diseases of the kidney. And my goal is simple, really. By the end of this session, I want you to be able to look at a biopsy slide and tell its story. So, let's begin, shall we?
So let's start with a big question. I want you to think of your kidney's glomerulus like a very, very fine chani, a tea strainer. Its job is to filter all the blood, keep all the good stuff in, and throw the waste material out. Simple. But what happens when this master filter, this chani of ours, gets all clogged up or even breaks? That is exactly what we are going to explore.
And here it is, our hero for today, the glomerulus. Just look at this beautiful, intricate structure. It's incredible. Each of your kidneys has about 1 million of these tiny little balls of capillaries, and they're working 24/7 for you. Their job is absolutely critical. But, even heroes can be attacked.
Okay, so let's dive right into this. We are going to look very closely at what happens when this delicate filtering system comes under attack. This is the world of glomerular disease, and trust me, understanding it is absolutely key to becoming a good doctor.
Essentially, there are 3 main villains, okay? 3 main ways the glomerulus gets damaged. First, you've got immune complexes. Just think of it as sticky biological gunk that just clogs up the whole filter. Second, a faulty complement system, which is kind of like your body's own army starting friendly fire on itself. And third, we have genetic defects.
which basically means the filter was built from faulty blueprints from the very beginning. So today, we're going to track down these culprits one by one. Right. Let's start with the most common villain of them all, the immune complexes. This is where your own immune system, which is supposed to be your protector, starts creating these sticky proteins that get trapped in the glomeruli and, well, cause all sorts of havoc. Our first case is MPGN, or membranoproliferative glomerulonephritis. Big name, I know. But what's really important to remember here is that MPGN is not one single disease. No, it's a pattern of injury. The name itself tells you the whole story. Membrano, because the membrane gets thick, and proliferative because the cells are multiplying like crazy. It's the kidney's reaction to being damaged. And this slide, this beautifully illustrates the classic sign. Look closely at those capillary walls. Do you see that double line? That, my friends, is the famous tram track appearance. This is a super high-yield buzzword for your exams, okay? It happens because the cells are desperately trying to build a new basement membrane around all those immune deposits, and in the process, they create this split, this duplicated look, just like railway tracks.
All right, let's move on to our next culprit, IgN nephropathy. Now, this one is very, very important because it happens to be the most common type of glomerulonephritis in the entire world. And the name, it just gives the whole game away. The problem here is the deposition of one specific antibody, immunoglobulin A, or IgA. Now let's do a little comparison. On the left, in MPGN, you can see the damage is on the periphery, right? On the capillary walls themselves, giving us that tram track. But on the right, in IgA nephropathy, look where all the action is. It's in the center. It's in the mesangium, which is like the supporting stalk of the glomerulus. It's all clogged up, it's hypercellular. So, what's the crucial point here? The location of the gunk tells us the whole story.
But how do we actually prove that it's IgA causing the problem? Well, for that, we use a very special technique. It's called immunofluorescence. We use antibodies that are designed to stick only to IgA and make them glow. And look at this. All that bright green stuff lighting up the mesangium, that's our culprit, IgA, caught red-handed. Or, well, I guess you could say green-handed in this case. This is what confirms the diagnosis.
Okay, so we've seen how the immune system can go wrong. But sometimes the problem isn't with what the body makes, but how the body is made. So let's now look at some genetic issues and these body-wide or systemic diseases that also attack the kidney.
Let's talk about Alport syndrome. This is a hereditary disease, so the problem here is a mutation in the gene for something called type 4 collagen. Now think of collagen as the steel rods that give structure to the glomerular basement membrane, the filter itself. In Alport's, the blueprints for making these steel rods are faulty. And when you take this faulty filter and you look at it under a really powerful electron microscope, this is what you see. This is another classic, absolutely unforgettable image. The basement membrane, it's irregularly thick and thin, it's split, it's laminated. It looks like a poorly woven basket, which is exactly why we call it the basket weave appearance. And of course, a leaky basket cannot filter anything properly.
Now, sometimes the kidney is just one victim in a body-wide crime spree. This is what happens in systemic diseases like lupus or SLE. Here, the immune system just produces a flood of autoantibodies and immune complexes that can deposit basically anywhere, causing widespread damage. And the kidney happens to be a favorite target. When this happens, we call it lupus nephritis.
In severe lupus nephritis, we see yet another classic sign. Just look at how thick and rigid these capillary walls look. They're called wire loop lesions. And the term is just perfect, isn't it? It's caused by massive immune complex deposits getting stuck right under the endothelial cells, making the whole loop look like a thick, stiff piece of wire.
Whew! Okay, so we've seen tram tracks, mesangial deposits, basket weaves, and wire loops. As future doctors, your job is to put all these visual clues together. So let's just make a quick summary, a rapid review, so you can learn to decode the biopsy report just like a detective.
Right, this is your high-yield cheat sheet. Take a screenshot of this, write it down, commit it to memory. It's so important. If you see tram track, you think MPGN. If you see mesangial deposits that are glowing for IgA, you think IgA nephropathy. The basket weave on an electron microscopy, it screams Alport syndrome. And those wire loop lesions, a classic sign of severe lupus nephritis. Linking the disease to its specific visual clue, that is the key.
So always remember this. Every single slide, every pattern, it tells a story about what is happening to our patient. Pathology is not just about looking at dead tissues. No, it's about understanding the living, breathing process of disease. The real challenge for you, as you go forward, is to learn how to read these stories so that you can change the ending for your patients. Keep studying and always keep asking why. Thank you.
Chalo bachcho, welcome to the class. Today we're going to take a really deep dive into renal pathology. These are some of the most critical kidney diseases you are absolutely going to see in your clinical practice. You know, understanding what's happening at the cellular level, that's the key to becoming a good doctor. So let's get started, shall we? So, what's our plan for today? Here's the roadmap. First, we'll see how the kidney reacts when it's under attack from bacteria. Then, we'll compare the short-term versus the long-term fight. After that, we'll look at how drugs and toxins can cause trouble. And finally, we'll uncover how high blood pressure quietly, silently, damages this really important organ. All right, let's jump into our first topic, kidney infections. So what happens when bacteria decide to invade this amazing filtering system of ours? Well, we call this condition pyelonephritis, and believe me, it's a serious business.
Now, to really get this, we have to ask a very basic question. When a kidney is under attack, what does it actually look like? What are the signs you can see with your own eyes?
Now, look here. Look closely at this slide. This is what we call the gross picture, what you see without a microscope. You see these little spots? These grayish-white dots on the surface? These are tiny abscesses, basically small pockets of pus. It's a clear sign that a huge battle is going on inside the kidney. This is the classic look of acute pyelonephritis.
And here, now we've zoomed in. We're at the cellular level. See all those tiny dark purple dots? Those are neutrophils, Bacho. They are the soldiers of our immune system. They've rushed to the scene of the crime, and they are flooding the kidney tubules to fight the bacteria. This massive flood of neutrophils is what causes all the inflammation.
Look, an acute infection is a very serious thing, and if you don't manage it properly, it can lead to some really bad complications. You have to remember these three. First, papillary necrosis. This is especially dangerous for diabetic patients. Then there's pyelonephrosis. What a nightmare. This is when the kidney gets blocked and just fills up with pus. And finally, a perinephric abscess. This is when the infection literally breaks out of the kidney. All of these are medical emergencies, okay?
Okay, now let's change gears a bit. Let's compare a single, short, fierce battle inside the kidney to a long, slow, grinding war. The way the kidney looks in these two situations is completely different.
Now this slide, Bacho, this is very important for your exams. So pay attention. Notice the big differences. In acute, you have active inflammation, neutrophils everywhere, but the glomeruli, the main filters, are usually safe. But in the chronic stage, the fight is over. And what's left behind? Scars. Deep, ugly, irregular scars. The tubules are destroyed and some areas start to look like, well, like thyroid tissue. We even have a name for it, thyroidization. It's a very unique finding.
The difference here is just, wow. It's night and day, isn't it? On the left, you see the active fire of the acute infection, with all those abscesses. But on the right, that's the tragedy of long-term infection. You see the permanent damage, the deep scars from battles fought long ago. This damage is irreversible, a constant reminder of the war that was fought inside this poor kidney. So what's the bottom line here? Pyelonephritis is an infection, okay? It can come up from the bladder or it can come through the bloodstream. And remember, problems like a blockage or urine flowing backward, they make the kidney a very easy target. Acute means neutrophils and active inflammation. Chronic means scarring, especially at the top and bottom parts, the poles of the kidney.
Right, now let's move to our next big enemy of the kidney. Think about it. The kidney is the body's master filter, so it's super vulnerable to anything we put into our system. In this section, we'll see how medicines, the very things that are supposed to heal us, can sometimes become the problem themselves.
First, let's learn the name. It's called tubulointerstitial nephritis, or TIN for short. Now, this is not pyelonephritis. The main problem here isn't a bacterial invasion. No, it's an inflammatory reaction. Basically, it's an allergic reaction. The body's own immune system is overreacting to a drug.
And here is the proof. The smoking gun under the microscope. You see all those bright pink cells scattered around? Those are eosinophils. Whenever you see a biopsy with tons of eosinophils like this, a little light bulb should go on in your head. Ding! It's a classic sign of a drug-induced allergic reaction.
Now, this slide is fantastic because it shows you the domino effect of something called acute tubular injury, or ATI. It all starts with some kind of insult, either not enough blood flow or a poison. This hurts the tubule cells. They get injured, they stop working properly, then they actually die and fall off, creating a roadblock inside the tubule. And the final terrible result? The kidney's filtration rate just drops like a stone. This slide shows the wreckage. You can clearly see the damaged tubules. Many cells are dead, necrotic, and all that cellular garbage is just clogging up the system. It's like a blocked drainpipe, but on a microscopic level. And this blockage is a huge reason why the kidney fails in ATI.
Understanding this clinical timeline is absolutely 100% vital for managing your patients. You have to know which phase they are in. The initiation phase is when the damage happens. The maintenance phase, that's the most dangerous time, when urine output is very low. But if the patient survives this storm, they enter the recovery phase. And here, suddenly, they can start producing huge amounts of urine because the damaged tubules haven't learned how to concentrate it again.
And finally, let's talk about a very, very common and very sneaky enemy of the kidney: hypertension, high blood pressure. Millions and millions of people have it, and many of them have no idea about the silent damage it is causing inside their bodies day after day.
So, on a macro level, what does long-term so-called benign high blood pressure do to the kidney? Well, it leaves a very specific mark. The surface becomes finely granular. It feels a bit rough, almost like grain leather. This is the outside sign of all the scarring happening on the inside. The proper medical term for this is nephrosclerosis. Nephro for kidney, sclerosis for hardening. It literally means a hardening of the kidney's blood vessels. And what causes it? The constant pounding, pounding, pounding from chronic high blood pressure.
This side-by-side comparison, this is a classic. You must burn this image into your brain. On the left, you see hyaline arteriosclerosis. The vessel wall is thick and has this glassy pink look. This is what you see in chronic benign hypertension. But on the right, oh my, look at that. It looks like the layers of an onion, right? The onion skin appearance. This is hyperplastic arteriosclerosis, and it is the sign of severe malignant hypertension. This is a medical emergency.
So, the key takeaway here is simple. High blood pressure damages the kidney by starving it of blood. The vessel walls get thick, the opening gets narrow, and the kidney tissue doesn't get enough oxygen. This lack of oxygen leads to scarring, and eventually the kidney just stops working properly. And that onion skin look, that's the signature of the most dangerous, life-threatening form of this disease.
Okay, let's bring it all home. Let's summarize the most important lessons from today. These are not just facts for you to memorize for an exam, okay? This is the knowledge you will carry with you to the wards, to the clinic. The knowledge that will help you actually help your patients. I want you to think of these not as a list of diseases, but as a set of clues. You are a medical detective, right? So, does your patient have a fever? Maybe it's pyelonephritis. Did they just start a new medicine? You should suspect drug-induced TIN. Was there a big shock or exposure to a toxin? That points to ATI. And a long history of high blood pressure? That is a huge red flag for nephrosclerosis. Your job is to connect the patient's story with these patterns. That's the real art of medicine. So I will leave you with this final thought. Mastering pathology, it's like learning to read a secret language. A language that is written in the cells of the human body. Every single slide we saw today tells a story. A story of a fight, of damage, of repair. Your job as future doctors is to learn how to read those stories, to understand them, and to use that knowledge to heal. So keep studying, keep asking questions, and never lose your curiosity for the incredible stories that are waiting for you to read.
Tika?
Hello, everyone, and welcome. The kidney, is one of our body's most amazing filters. But what happens when this filter starts having problems? Well, today, we're going to take a tour of the troubled kidney. We'll look at everything from tiny little blood clots that you can only see with a microscope to massive destructive cysts. These are conditions that can really impact the body, so pay attention and let's get started. First things first, have a look at this. Now, this is a human kidney, but does it look like one? No, it looks more like a bunch of grapes, isn't it? It has been completely, absolutely taken over by these fluid-filled sacs we call cysts. What on earth could cause such a dramatic change? We'll solve this little mystery a bit later in our class. So, here is our plan for today. We'll start by looking at problems deep inside the kidney's smallest blood vessels.
Then, we'll discuss a tale of two very similar but oh so different clotting problems. After that, yes, we will solve the mystery of that grape cluster kidney, and we'll finish up with some common plumbing issues like blockages and stones before I give you the key takeaways you absolutely must remember. So let's dive right in. We're starting at the microscopic level, okay? With the tiny, tiny capillaries and arterioles inside the kidney. This is where big trouble can start, when these smallest of pipes get clogged up. Now, the key term here is thrombotic microangiopathies, or TMAs. I know, it's a big, scary name, but the idea is actually quite simple. It just means that tiny blood clots are forming in the body's smallest vessels. And this blockage, it chokes off the blood flow, which means the tissue doesn't get oxygen and starts to die. And that process, as you know, is called ischemia. And here, you can see this happening with your own eyes. This is a glomerulus, one of the kidney's little filtering units. You see those bright red masses that are blocking everything up? Those are the thrombi, the clots we were just talking about. This is exactly what a TMA looks like under the microscope, and this is what's causing all the damage. Now, while all these TMAs involve these tiny clots, they are not all the same. Not at all. We need to introduce the two main characters in this story, HUS and TTP. So the two conditions are HUS and TTP. Now, under microscope, they can look almost identical, but, and this is very important, their underlying causes are completely different. And this difference is absolutely critical because getting the diagnosis right will decide the patient's entire treatment and their chances of getting better. And this table here explains the difference so nicely. Just look. The typical HUS is usually caused by a nasty toxin from bacteria, like E. coli. Then there is an atypical HUS, which is usually a problem with our own immune system's complement pathway going crazy. And TTP? That's a completely different story. It's typically caused by a deficiency of a specific enzyme called ADAMTS13. See? Different causes, and so, different treatments. So let me make it very simple for you. In HUS, the main problem is damage to the endothelium, the lining of the blood vessel. The vessel wall gets hurt first, and that is what triggers the clotting. But in TTP, the problem starts with the platelets themselves. They just become too sticky and start clumping together, forming clots without any initial injury to the vessel wall. It's a crucial difference. Okay, let's change gears now. We're moving away from the blood vessels and looking at the building itself, the architecture of the kidney. And this brings us back to that strange grape cluster kidney we saw right at the beginning. And here is our answer: autosomal dominant polycystic kidney disease, or ADPKD. This is a very important genetic disorder and actually one of the most common hereditary reasons for kidney failure. Over many years, the kidneys fill up with countless cysts that just keep expanding, destroying all the normal, healthy tissue around them.
So how do these cysts even form? Well, it all starts with a mistake, a mutation, in one of two genes, usually a gene called PKD1. Now, this mistake affects the tiny antenna-like thing on the kidney's tubular cells called a primary cilium. This little antenna is supposed to sense the flow of urine, but when it's faulty, it can't. This messes up all the signals inside the cell, leading to uncontrolled growth and fluid secretion, and poof, you get a cyst. It's a chain reaction.
Now, this slide shows a very interesting comparison. On the left is the adult form of PKD we've been talking about. You can see these huge irregular cysts, like big bubbles. But on the right is the much rarer childhood form. Here the cysts are smaller, more uniform, giving it a spongy look, no? So two related diseases, but they look very, very different. And very importantly, you must remember that ADPKD is not just a kidney disease. The genetic problem can cause issues all over the body. Patients often get cysts in their liver, and even more dangerously, they can form these berry aneurysms in the brain, which carry a very serious risk of a fatal rupture. It is a truly systemic disease. All right, for our final section today, let's talk about some basic plumbing. What happens when the kidney's drainage system gets blocked? This is what we call obstructive uropathy. Now, a blockage can happen anywhere along the urinary tract, and for so many reasons. It could be something you are born with, a congenital issue, or it could be acquired later, like kidney stones, an enlarged prostate in men, or even a tumor pressing on the ureter. The list of causes is very long. And what is the result if a block is there for a long time? This condition is called hydronephrosis. The urine backs up, and the renal pelvis and calyces swell up like a water balloon. You can see how the pressure has flattened everything out,
and made the cortex so thin. The functional tissue, the parenchyma, is slowly being destroyed.
And what is the most common cause of this kind of obstruction? Kidney stones. As this chart shows, the vast majority, something like 70%, are made of calcium oxalate. Other types, like struvite or uric acid stones, are less common but still very significant.
And sometimes these stones can become absolutely enormous. Look at this one here. It's called a staghorn calculus because it has grown to fill the entire renal pelvis and calyces, taking on the shape of a deer's antler. These are often struvite stones, which we frequently see with chronic urinary tract infections. We've covered a lot of ground today, haven't we? So let's pull it all together and review the key points, the high-yield facts from our tour of the troubled kidney. This is important for your exams.
So, to summarize, TMAs are tiny clots, remember, caused either by vessel wall injury in HUS or overactive platelets in TTP. Next, ADPKD is a genetic disease where those faulty cellular antennas lead to massive destructive cysts. Then obstruction is a blockage that causes urine to back up, leading to pressure damage called hydronephrosis. And finally, stones are the #1 cause of that obstruction, and most of them are made of calcium. This is a powerful reminder, isn't it? It shows how this amazing organ can be attacked from so many different angles, from its tiniest vessels to its overall structure. The kidney truly is the body's master filter, and understanding what happens when it breaks down is the very first step to protecting it. Thank you.